welcome to The Funnel Effect. We are diving deep today into, well, what feels like a genuine revolution in cardiology. It's this massive shift away from just keeping hearts beating with pacemakers towards something much smarter, true physiological pacing. We're not just talking small tweaks here. It's really a whole new way of thinking, moving from, let's say, basic electrical fixes to trying to copy the heart's own sophisticated design.
Absolutely. And for this crucial deep dive, we're drawing heavily from a fantastic source. It's a comprehensive review titled Physiological Pacing, Mechanisms, Clinical Indications, and Perspectives. It was published in the European Heart Journal. And we really need to credit the authors, Zachary Winnett, Akriti Narayan, Pugazendi Vijayaraman, John G.F. Cleland, and Daniel Keene. Their work really lays it all out.
Okay, so our mission today is pretty layered. First, we had to unpack the history a bit, how pacing started. Then, critically, understand why those early foundational methods actually turned out to be harmful in the long run. And then we get to the exciting part, exploring these newer techniques, this conduction system pacing, or CSP. How are they actually restoring the heart's natural electrical flow? And, what's really interesting is how this is pushing treatment way beyond just managing slow heart rates, bradycardia.
Yeah, and to really grasp this, you've got to start with the basics, the normal heart. It relies on this incredibly elegant, super efficient conduction system. Think of it like perfect wiring. This network makes sure everything's timed just right, the chamber's filling, the speed, the signal travels, the big squeeze of the ventricles, it all has to be perfectly synchronized. When disease hits this network, the problems aren't subtle. It's not just about a slow pulse. It affects everything: how well you can exercise, causes shortness of breath, fatigue, and it seriously impacts long-term survival.
Right. So let's start with that blueprint. Can you just walk us through that perfect electrical journey? How does the signal normally travel so fast and efficiently?
Sure. It all kicks off in the sinoatrial node, the heart's natural pacemaker up in the right atrium. From there, the signal zips down three main pathways, internodal pathways, across that right atrium. And crucially, it uses a specific high-speed track called Bachmann's bundle to jump over to the left atrium almost instantly. Once the atria have done their thing, the signal hits the AV node. There's a tiny necessary pause there, allows the ventricles to fill properly, and then it hits the accelerator, the His-Purkinje system. This is this amazing network of fibers that just blasts the signal out across both ventricles simultaneously. That's what guarantees that rapid, coordinated contraction we need.
It really does sound like a perfectly timed relay race. So it follows that if there's a problem, a block somewhere in that relay, the type of problem you get depends entirely on where the block is, right?
Exactly right. The consequences are very specific to the location. So if the problem's high up in the sinus node itself, you mainly get bradycardia, a slow heart rate, which reduces cardiac output. That can also stir up other atrial rhythms. Now, if the delay is in the atrial part, say, a block in that Bachmann's bundle highway well, that messes up how the left ventricle fills. It pushes left atrial pressure up, and this is really important. It significantly increases the risk of developing chronic atrial fibrillation, AF.
And presumably the most damaging functional issues, the ones we really associate with worsening heart failure, happen lower down, in the bundle branches.
That's where you get the classic left bundle branch block, or LBBB. Usually that's caused by disease right at the His bundle, or just as the left bundle takes off. And the effect on coordination is, well, profound. It's really bad for efficiency. Instead of that quick synchronized squeeze, LBBB causes this messy, uncoordinated activation of the left ventricle. You get severe dysynchrony between the ventricles, and the timing between the left atrium and ventricle gets stretched out. This electrical mess directly leads to an inefficient pump, lower ejection fraction, just poor performance overall.
Okay, now let's fast forward to the 1960s. Pacemakers arrive. Miracle technology, right? Solved that immediate life-threatening problem of complete heart block, kept people alive. But here's the twist, the major pivot point for our whole discussion today. That initial approach, right, ventricular pacing, RVP, turned out to be fundamentally flawed.
It's the central paradox that really kicked off this whole revolution. You see, when you pace the heart conventionally, usually sticking the lead down in the apex, the tip of the right ventricle, you fix the rate problem, yes, but you create a really serious timing problem. The source material we're looking at is crystal clear on this. RVP causes non-physiological ventricular activation. The electrical signal doesn't use those fast Purkinje highways. Instead, it has to creep slowly from muscle cell to muscle cell. And we now understand RVP structurally and functionally as basically a form of iatrogenic conduction system disease. That means it's a disease caused by the medical treatment itself.
Wow. Iatrogenic conduction disease. Creating a chronic problem while fixing an acute one, that's a pretty sobering thought. What are the actual measurable downstream effects of forcing the heart to beat in this unnatural, slow-spreading way?
Well, because the signal spreads so slowly from the RV apex, the main pumping chamber, the left ventricle's free wall, contracts much later than the septum, the wall between the ventricles. That creates significant mechanical dyssynchrony. This messes up the function of both ventricles, lowers the overall cardiac output, and over time it can even compromise the heart's own blood supply, reducing myocardial perfusion. We also see mechanical knock-on effects, like the heart valves becoming leaky functional mitral and tricuspid regurgitation. And importantly, it bumps up the long-term risk of developing atrial fibrillation.
And this damage isn't just theoretical, it has a name: pacing-induced cardiomyopathy, or PICM. And you're saying we have solid clinical proof this happens.
Oh, absolutely. PICM is very well documented. We've seen it in large retrospective studies, and crucially, in big, important randomized controlled trials, RCTs. Look at the David trial, for instance. That trial directly compared programming pacemakers to pace the ventricle a lot versus programming them to pace as little as possible. The patients programmed to DDR70, that's a mode designed to ensure a high percentage of RV pacing well. They had significantly worse survival and more heart failure hospitalizations compared to those programmed just for backup pacing.
Let's pause on that DDR70 mode for a second for listeners who might be learners here. That's essentially the standard functional way many pacemakers were programmed, right? So the David trial basically showed that simply using the pacemaker frequently in that standard way was the problem.
Exactly. It wasn't the device itself being faulty. It was the high volume of non-physiological pacing that was harmful. The more you relied on RVP, the worse patients did. But maybe the most striking data came from the MOST trial. This one specifically looked at patients with sick sinus syndrome. So, problems with the natural pacemaker, but who started with normal LV function. And the finding here was, frankly, a bombshell. It showed that for every 10% increase in the amount of time the patient's ventricle was paced by the device, there was a shocking 20% increase in the relative risk of being hospitalized for heart failure.
Wait, see that again. A 20% higher risk of heart failure hospitalization for every 10% increase in RVP. That's huge, especially in patients who started with normal hearts. That single statistic from most must have sent shockwaves through cardiology. It basically mandated trying to minimize RVP whenever possible.
It was definitive proof. RVP could save your life in the short term, but it was like a slow poison for the heart muscle over time. It really provided the ultimate push for this whole physiological pacing movement. And now we have a pretty clear picture of who's most at risk for PICM. Patients who need a lot of pacing, anyone with even mild pre-existing LV weakness, men seem more susceptible, those with a wider baseline QRS complex, and older individuals. This knowledge shifted the goalposts. It wasn't just about rate anymore, it was about minimizing the disruption caused by the pacing itself.
Okay, so clinicians realized RVP was toxic long-term, but they couldn't just stop using pacemakers. While waiting for completely new approaches, they had to get smarter with the existing tech, right? These were the first sort of incremental steps towards physiology.
That's right. The first fixes were all about trying to let the heart do its own thing as much as possible, promoting intrinsic activation. The big early concept was demand pacing. You see, the very first pacemakers were fixed rate. They just fired at a set rhythm no matter what the heart was doing naturally.
Which sounds dangerous. If the heart had its own beat, the pacemaker firing at the wrong time could cause trouble.
Exactly. That fixed-rate pacing could land a stimulus right during the heart's vulnerable electrical recovery period, the infamous R-on-T phenomenon, which could trigger lethal arrhythmias. Demand pacing was smarter. It had sensing circuits. It listened for the heart's own spontaneous beat, the depolarization. And if it detected one, it withheld the pacing pulse. It only paced if the heart's own rhythm failed. Much safer, and it allowed the natural rhythm to take precedence.
Okay, safer. But people still needed to function. Your heart rate naturally speeds up when you exercise. Old pacemakers kept you alive sitting still but left you breathless climbing stairs.
Right. That led to rate response technology. This meant building sensors into the pacemaker generator itself, usually accelerometers like in your phone to detect body movement, or sometimes sensors measuring minute ventilation, basically, how fast and deep you're breathing. These sensors allowed the pacemaker to estimate your metabolic demand and automatically increase the pacing rate during activity, mimicking the body's natural response. This made a huge difference to patients' functional capacity and just their overall quality of life.
So we've got rate covered, but what about basic coordination? You need the atria to contract before the ventricles, that atrial kick. to really maximize the pump function.
That naturally led to atrioventricular sequential pacing, or what we commonly call dual chamber pacing. You put leads in both the atrium and the ventricle. By ensuring that coordinated sequence, atrium contracts, then ventricle contracts, you preserve that vital atrial kick. Studies showed this approach increased cardiac output by a really significant amount, somewhere between 14% and 25% compared to just pacing the ventricle alone, VVI mode. Symptomatically, patients felt much better.
Okay, a 14–25% boost in cardiac output sounds pretty dramatic. Why didn't dual chamber pacing just become the default and solve the whole RVP problem then?
Well, here's the catch. While symptoms and quality of life clearly improved with dual chamber pacing, the big, large-scale randomized trials like the UK PACE trial, led by Toff and colleagues, failed to show a significant reduction in mortality compared to simpler single-chamber ventricular pacing. So it improved the timing between the chambers, yes, but it did absolutely nothing to fix that fundamental flaw. The slow, unnatural way the electrical impulse spread within the ventricles because of the RVP-led position, the core problem remained.
Right. So if they couldn't avoid RVP entirely for many patients, the next logical step, I guess, was trying to find a less bad spot to put that ventricular lead. That led to the idea of pacing the septum, the wall between the ventricles, instead of the apex.
Exactly. The thinking behind RV septal pacing, RVSP, or sometimes pacing the RV outflow tract near the top of the ventricle, was theoretically sound. The idea was maybe if you place the lead closer to the heart's natural conduction system, away from the apex, the electrical wave would spread out more naturally, maybe result in a narrower, more synchronized QRS complex on the ECG.
Seemed logical. But the results in practice?
Hugely disappointing, unfortunately. Trial after trial struggled to show any consistent, meaningful benefit in terms of LV function, symptoms, or outcomes compared to traditional apical pacing. And looking back, this failure was maybe predictable, and it actually served a crucial purpose. It highlighted why a more radical approach was needed. The failure boiled down to two main things. First, even if you place the lead perfectly on the septum, you were still relying on that slow, inefficient cell-to-cell muscle activation. Moving the lead's origin point a bit didn't fundamentally change the slow spread. Second, frankly, achieving precise septal placement consistently was difficult. Post-implant imaging often showed leads intended for the septum were actually sitting somewhere else, often far away on the RV free wall, which is certainly no better than the apex.
So the failure of RV septal pacing really hammered home the point. Fiddling with the location wasn't enough. You couldn't just pace the muscle better. You had to fundamentally change the strategy and figure out how to engage the heart's own high-speed wiring. And that finally brings us to the real game changer, conduction system pacing. Okay, so before jumping fully into this new CSQ world, there was sort of an intermediate step using technology already available for heart failure, biventricular pacing, or BVP. That's the system with leads in both the right and left ventricles, typically used for CRT. Did they try using that for regular bradycardia patients to avoid the downsides of RVP?
They certainly did. BVP was explored as an alternative to RVP. The logic was, well, hitting both ventricles at roughly the same time should be better than just the right ventricle alone. But the results turned out to be really dependent on how healthy the patient's left ventricle was to begin with. We have two major trials here that actually showed quite different things, which illustrates the point perfectly.
Okay, let's take the one where BVP looked good first. That was the BLOCK-HF trial.
Correct. BLOCK-HF looked specifically at patients who needed pacing because of AV block and who already had weakened hearts. Their left ventricular ejection fraction, LVEF, was 50% or less. And importantly, about a third of them had quite severe dysfunction, LVEF under 35%. In this group, this sicker group, BVP clearly came out on top compared to RVP. It led to better LV function, fewer heart failure hospitalizations, and even a trend towards better survival. So for patients with already compromised hearts, BVP seemed protective against the harm of RVP.
But that wasn't the whole story, was it? The later, much larger BioPACE trial gave a different result for the, let's say, more typical bradycardia patient.
Exactly. BioPACE was a big trial, over 1,800 patients, and the key difference was that most of these patients, nearly 70%, had normal or near normal heart function, LVEF 50%. They needed pacing mainly for rate support due to AV block or sinus node disease, but their pumps were generally okay. In this larger, healthier cohort, BioPACE found no significant difference between getting BVP versus standard RVP when they looked at the main combined outcome of death or heart failure hospitalization.
Okay, so if BVP is definitely more complex, involves placing an extra lead, usually via the coronary veins, more costly, and BioPACE showed no real benefit over simple RVP in the majority of patients with good hearts, Why didn't that just kill BVP for bradycardia then?
That's precisely why BVP didn't become the universal standard for all bradycardia patients. BLCK-HF showed it helped the sicker ones. BioPace showed it didn't help the healthier majority. Clinicians were left in a bit of a gray zone. It basically confirmed that just pacing two spots on the muscle wasn't the ultimate physiological answer either. It sort of paved the way, highlighting the need for something even better, something that truly restored natural activation. And that's conduction system pacing.
Right. Let's nail down the core idea of CSP again. What's the fundamental principle?
The principle is simple but powerful. Instead of pacing the heart muscle and relying on slow cell-to-cell spread, you aim to place the pacing lead directly onto the heart's own high-speed electrical wiring, the His-Purkinje system. The goal is to recruit those native fibers, hijack the natural system, and restore that rapid, elegant, synchronized ventricular activation the heart was designed for.
And the first, most obvious target for that, the one that seemed theoretically perfect, was his bundle itself. His bundle pacing, or HPP. That should give you the perfect beat, shouldn't it?
Conceptually, yes. HPP is often called the most physiological pacing method. You stimulate the His bundle directly. The signal then travels down the left and right bundle branches exactly as it should, giving you true, simultaneous, rapid activation of both ventricles. And confirming you've successfully captured the SEB, His bundle is relatively straightforward based on the ECG. Initial studies showed it was feasible. People could implant these leads successfully.
So if it's the theoretical gold standard, why didn't HPP just take over immediately? What were the practical hurdles that stopped it from becoming the default?
There were some significant challenges, unfortunately. They fall into roughly 3 buckets. First, the procedure itself can be trickier and take longer. The His bundle is a pretty small target, deep in the heart, so finding it and getting stable lead placement isn't always easy. Second, the energy required to reliably capture the Whaler. His bundle, the pacing threshold, is often higher than for standard RVP. This means the pacemaker battery drains faster, potentially requiring earlier replacements. But the real deal breaker, the major obstacle, turned out to be long-term stability. Large studies started reporting that thresholds could rise late and unpredictably, sometimes months or years after implant, in up to 12% of patients. This meant the pacing could suddenly stop working, leading to symptoms coming back. And this instability translated into a pretty high rate of needing lead revisions going back in to fix or replace the lead, somewhere around 7%. That's just too high for a device meant to last many years.
Yeah, a 7% reoperation rate because the lead stops working reliably. That's a non-starter for widespread adoption. So that instability, plus the procedural complexity, must have been the main driver for exploring the other main CSP technique, left bundle branch area pacing, or LBBAP.
Absolutely. LVBB was developed specifically to try and capture the physiological benefits of his pacing, but overcome those critical stability and threshold issues. It uses a different implantation technique. Instead of aiming for the tiny His bundle on the surface, LBBP involves carefully screwing the pacing lead deeper into the interventricular septum, the muscular wall between the ventricles, specifically targeting the area where the left bundle branch, LBB, is running. And the early observational data was really promising. It showed consistently high implant success rates, good electrical signals for the pacemaker to sense, large R waves, and crucially low and remarkably stable capture thresholds over the long haul.
Now, this is where it gets a bit technical, but it's really important for anyone learning about this. LBBAP isn't just one thing. There are different types of electrical capture you can get. Can you break those down? It's not just on or off, right?
You're absolutely right. Understanding the capture type is key, as it affects the resulting QRS complex and is a big focus of current research. There are basically 3 main patterns we talk about. The first, and maybe the most purely physiological, is selective LBBP. This happens when the pacing stimulus captures only the left bundle fibers themselves without stimulating the surrounding heart muscle directly. This gives you a QRS morphology that looks very much like the patient's natural narrow beat, if they had one. But it's often only seen at very low pacing outputs, like during threshold testing, and it's rarely the mode used for chronic pacing because you need a bit more energy for safety margin.
Okay, so if selective is rare for chronic pacing, what's the usual target, the common, clinically relevant mode?
That would be non-selective LBBP. In this case, the pacing lead, being embedded in the septum, captures both the left bundle fibers and the adjacent septal heart muscle simultaneously. Because the lead is deeper and usually needs a bit more energy for reliable capture, you recruit both the fast pathway and the local muscle. This seems to provide that stable, low threshold pacing that makes LBBP attractive. This is generally the goal.
And the third possibility?
The third category is left ventricular septal pacing, LVSP. Here, the lead is definitely in the LV septum, and it's capturing the muscle tissue there, but we can't confirm that it's also capturing the actual conduction system fibers, the LBB. The resulting QRS is usually narrower and better than RVP from the apex, but it might still rely more on slower muscle-to-muscle conduction rather than truly hijacking the LBB. Distinguishing between non-selective LBBP and LVSP just by looking at the surface, ECG can sometimes be tricky, but the underlying activation pattern is different.
Okay, that makes sense. Now, safety drilling lead deep into the septum sounds potentially risky. Any concerns about perforating the wall or other issues? What did the big safety studies like Menlos show?
That's a fair question. The Mellos registry looking at over 2,500 LB-baby implants gave us some good reassurance. Initially, the reported rate of any adverse event was around 11–12%, but most of these were minor lead issues like dislodgement or sensing problems. The main procedural complication specific to the technique was indeed septal perforation, the lead going all the way through, which happened in about 3.7% of cases. However, the crucial point from the source is that if this is recognized during the procedure and the lead is simply repositioned or pulled back slightly, it's usually benign with no long-term consequences. Looking more broadly, a meta-analysis covering over 6,000 patients put the rate of serious procedural adverse events related to LBBA quite low, around 2.5%. So generally considered safe when done by experienced operators.
Right, so feasibility looks good, stability seems much better than HBP, and safety is acceptable. Where does CSP stand now in the official clinical guidelines for patients just needing pacing for bradycardia?
It's made significant headway, given the clear physiological advantages and the mounting evidence suggesting it's better than RVP, especially in patients at risk of heart dysfunction. The major international guidelines, like the 2023 HRSF guidelines, now give conduction system pacing, that's either HBP or LBBAP, a strong Class 2A recommendation. Specifically, this applies to patients needing a pacemaker for bradycardia who also have somewhat reduced heart function, LVEF between 35% and 50%, and are expected to need a lot of ventricular pacing. Basically, the group most likely to develop PICM from standard RVP. For them, CSP is now strongly suggested as the preferred approach.
That's a big endorsement. The 2A recommendation is pretty strong. What are the key trials we're waiting on now that could potentially elevate CSP to a Class 1 recommendation, making it the standard of care for most bradycardia patients, maybe even those with normal hearts?
Yeah, the results from the big, ongoing, randomized controlled trials are really what everyone's waiting for. These are the definitive head-to-head comparisons. We're looking closely at trials like PROTECT-HF, Optum Pacing, and LEAP, among others. These trials are randomizing patients needing pacing for bradycardia to either get CSP, usually LBBOP in the newer trials, or standard RVP. And they're looking at hard clinical outcomes, things like the combined rate of death, heart failure hospitalizations, and objective changes in heart function on echo. If these trials clearly show that CSP leads to better outcomes across the board, even in patients starting with good LVEF, then yes, that would almost certainly shift the guidelines and make CSP the new standard, replacing RVP for the vast majority of bradycardia pacing indications.
Okay, let's shift gears now. We've talked about fixing a slow rate. Now let's talk about fixing a timing problem specifically, left bundle branch block, LBBB. We already established LBBB is really bad news, especially in people with weakened hearts. The first big breakthrough therapy here was biventricular pacing used specifically for cardiac synchronization therapy, or BVP-CRT.
Right. BVP-CRT was a massive advance when it came on the scene. The whole goal was different from just bradycardia pacing. Here, the aim was to overcome the electrical delay caused by the LBBB and resynchronize the contraction of the two ventricles while also optimizing the timing between the atria and ventricles. And the evidence supporting BVP-CRT is incredibly strong. We have multiple landmark clinical trials, meta-analyses. It's rock solid. They all confirm that BVP-CRT significantly cuts down heart failure hospitalizations and reduces mortality in the right patients. That's typically patients with symptomatic heart failure who are normal sinus rhythm, have LBBB on their ECG, and importantly, a very wide QRS complex, usually over 150 milliseconds. For that group, BVP-CRT earned a very firm Class 1A recommendation in the guidelines, the strongest possible endorsement.
So if BVP-CRT has such a strong recommendation and proven benefit, why are we even talking about alternatives like CSP for these patients? What are the downsides or limitations of traditional BVP-CRT?
There are definitely limitations, both practical and physiological. On the practical side, getting that third lead, the LV lead, positioned correctly in a coronary sinus vein on the outside of the left ventricle, Well, it's tricky. It simply fails due to anatomical reasons or inability to find a stable position in a significant minority of patients, somewhere between, say, 3.5% and maybe up to 10% of attempted implants.
Okay, so implant failure is one issue. What about physiologically? Does BVP-CRT share that same core flaw we talked about with RVP in that it's still pacing the muscle, not the wiring?
Exactly. That's the crucial physiological limitation. BVP-CRT does not restore truly normal physiological ventricular activation. It's still relying on two pacing sites stimulating the muscle and the electrical wave spreading relatively slowly cell to cell from those points. While it's better than just RVP, it usually only achieves modest shortening of the QRS duration. And here's a key insight highlighted in the source material. Detailed studies looking at the immediate hemodynamic effects suggest that a huge chunk, maybe around 70% of the benefit seen with BVP-CRT, might actually come just from optimizing the timing between the atrial contraction and the ventricular contraction, the AV delay, rather than from perfect resynchronization of the ventricles themselves.
Wow, 70% just from getting the AV timing right. That's really interesting. It suggests that while making the QRS narrower is good, maybe the most critical part is just ensuring the ventricle contracts at the optimal moment after the atrium fills it.
It certainly shifts the perspective. And because BVP-CRT relies on that slower muscle activation, it can never fully replicate the speed and efficiency of the native conduction system. This naturally leads to the question, could CSP do a better job for CRT? Which brings us to his CRT and LBBAP CRT.
Okay, let's start with his CRT. The logic seems clear. If the LBBB is caused by a block high up in the His bundle, or just below it, pacing the MAPI, his bundle distal to the block should bypass the problem entirely and restore perfect conduction down both bundle branches, right?
That's the potential power of his CRT. If the block is proximal, HBP can theoretically correct the LBBB completely, recruit all the downstream fibers, and provide much more effective ventricular resynchronization and faster LV activation than BVP-CRT ever could. The big if, though, is that it only works if the block is proximal and correctable. If the disease causing the LBBB is further down, more diffuse within the bundle branches, then pacing his bundle won't fix it. Clinicians use certain ECG features like the Strauss criteria to try and predict who has this kind of correctable proximal block and might be a good candidate for a CRT.
So that dependence on a proximal block is a key limitation for his CRT. And this is where LBBB CRT comes in again, potentially being able to capture the left bundle even if the block is a bit further down.
Yeah.
But this introduces that paradox you mentioned earlier.
Exactly. LBBAP, by its nature of targeting the left bundle area directly, might be able to overcome more distal blocks within the left bundle system that his pacing can't reach. That's the advantage. But here's the LBBAP CRT paradox. When you pace the left bundle area strongly enough to capture it reliably, you often get very rapid activation of the left ventricle. But the activation of the right ventricle might lag behind because the signal has to cross the septum. This can actually create RV delay. So to get the narrowest possible QRS complex, which is often the goal in CRT, LBBB frequently requires careful programming to fuse the paced beat with the patient's own intrinsic conduction coming down the right bundle branch, if they have any. They call this using fusion-optimized intervals, or FOI.
And why is relying on this fusion approach potentially problematic, especially for CRT patients who often have complex issues?
It creates a potential trade-off. Achieving and maintaining that perfect fusion can be tricky, especially in patients who have complete heart block, no intrinsic conduction, or who are in persistent atrial fibrillation, where the intrinsic rhythm is chaotic. More importantly, optimizing the pacing timing, the AV delay, and the VV delay purely to achieve the narrowest possible QRS through fusion might force you to compromise on what would otherwise be the optimal AV delay for maximizing that beneficial atrial kick. And since we just discussed that optimizing AV delay might contribute up to 70% of CRT's benefit, sacrificing that optimal AV timing just to get a slightly narrower QRS via fusion might not actually be the best overall strategy for the patient. It's a complex balancing act.
Okay, so there are technical challenges, but despite that complexity, what are the early results looking like when people compare LBBB CRT directly to the traditional BVP CRT, even if it's mostly observational data so far?
The observational data has been remarkably positive, actually. Multiple studies comparing patients receiving LBBA-PCRT versus BV-PCRT have reported that LBBV appears to be associated with better outcomes. Specifically, they've seen things like improved survival, greater improvements in the LVEF, the heart's pumping strength, more significant shortening of the QRS duration, and interestingly, even a lower burden of subsequent ventricular and atrial arrhythmias compared to BVP-CRT. It really suggests that restoring activation via the natural conduction pathway, even with the paradox, might be clinically superior.
That's very persuasive observational data. But as always in medicine, we need the definitive randomized trial. Is there a big one underway?
Yes, there is. The results are eagerly anticipated from a large international multi-center randomized trial. The identifier is NCT05650658. It's aiming to enroll over 2,100 patients with standard indications for CRT. They'll be randomly assigned to get either LBBA-PCRT or conventional BV-PCRT. The trial will look at hard clinical endpoints like death and heart failure hospitalizations. This trial is really expected to provide the high-level evidence needed to determine if LBBA should replace BVP as the preferred method for delivering CRT.
All right, this last section is really exciting as it shows how understanding physiological timing is opening up completely new potential uses for pacing, way beyond just slow heart rates or LBBB. Let's start with something seemingly simple, a long PR interval on the ECG.
Yeah, a long PR interval, which means slow conduction through the AV node, isn't just an electrical finding. It has real functional consequences. It causes the atria to contract too early relative to the ventricles, sometimes even against a closing valve. This increases the pressure in the atria, reduces the heart's overall efficiency because you lose some of that optimal filling, and it's been independently linked to worse long-term outcomes.
So the HOPE-HF trial tested using his bundle pacing, optimized for AV timing, in these patients. Did it improve their ability to exercise?
Interestingly, no, not directly. The primary endpoint of HOPE-HF was peak oxygen uptake, a standard measure of exercise capacity, and that didn't significantly improve with the AV-optimized HBP compared to standard pacing. However, and this is key, the trial was double-blinded, and it did show statistically significant improvements in patient-reported quality of life scores. So even though it didn't boost their peak exercise on a test, optimizing that AV timing physiologically made the patients feel substantially better day to day.
That's important. Feeling better matters. Now let's move up into the atria themselves. This idea of atrial resynchronization using Bachmann's bundle pacing, BBP, sounds really cutting edge.
It's a fascinating concept. We know that slowed conduction between the two atria-interatrial conduction delay is really common, especially in patients with heart failure with preserved ejection fraction, HFpEF. When the signal travels slowly across the atria, the left atrium contracts too late. This delay raises the pressure inside the left ventricle as it tries to fill a major problem in HFpEF. And standard pacing, just putting a lead in the right atrial appendage, can actually make this interatrial delay worse.
So BBP tries to short-circuit that delay by pacing near that natural high-speed track between the atria.
Precisely. By pacing near or on Bachmann's bundle, the main interatrial highway, you aim to reduce that pathological delay and get the two atria contracting more synchronously again. And the potential payoff here looks really exciting based on early data, both observational and some randomized comparisons. It seems that BVP might significantly reduce the progression to persistent or chronic atrial fibrillation compared to just pacing the right atrial appendage. If true, that's huge, directly linking physiological atrial timing to preventing a major arrhythmia.
Okay, let's swing back to HFpEF itself. We know it's notoriously hard to treat with drugs, and one common issue in HFpEF is chronotropic incompetence. The heart rate just doesn't speed up enough during exercise.
That's right. And this is where pacing challenges some long-held beliefs. We know beta blockers, which slow the heart rate, are cornerstones for treating heart failure with reduced ejection fraction, HFrEF. But HFpEF is different. These patients often have stiff, non-compliant ventricles. Their hearts don't stretch well to accommodate more blood, fixed stroke volume. If you slow the heart rate down too much with drugs, you just prolong the filling time against this stiff ventricle, which can actually increase filling pressures and make symptoms worse, not better.
So the counterintuitive idea, tested in the MyPace trial, was that maybe for these stiff hearts, pacing them faster might actually be beneficial.
Exactly. It seems backwards based on HFrEF logic, but the MyPace trial investigated exactly that. They took HFpEF patients with pacemakers and randomized them to either standard pacing around 60 BPM or an accelerated pacing algorithm designed to keep their heart rate higher, especially during activity. And the results were striking. The group randomized to the accelerated pacing strategy reported better quality of life, they were objectively more active, measured by the pacemaker's sensors, and they had less device-detected atrial fibrillation compared to the standard rate group. It strongly suggests that for certain heart conditions like restrictive HFpEF, where the ventricle volume is relatively fixed, optimizing the rate, potentially keeping it higher, might be a more critical therapeutic target than just trying to reduce demand by slowing it down. It really challenges the one-size-fits-all approach to rate control.
Fascinating stuff. Lastly, what about the really tricky conduction problems, the ones that aren't classic LBBB, like right bundle branch block, RBBB, or that vague category, non-specific intraventricular conduction delay, NSIVCD?
Yeah, these are challenging groups. For RBBB, traditional VVP-CRT has shown pretty limited and inconsistent benefit. It doesn't seem to work very well. However, there's emerging evidence, mostly from smaller studies so far, that conduction system pacing, especially HBP-CRT, might be effective. The idea is that HBP might be able to pace distal to the RBBB block, or perhaps just optimize septal activation in a way that helps overcome the delay. Some studies showed HBP-CRT significantly reduced QRS duration and improved LVEF in a good proportion of RBBP patients who didn't respond to BVP.
Okay, and for NSIVCD, that sounds like a diagnosis for when the QRS is wide, but it doesn't look typically like LBBB or RBBB.
Right. It's often a mix of conduction disease and underlying muscle disease, myopathy. This group has arguably the most conflicting data on whether BVP CRT helps them. So for these really complex cases, we're seeing the rise of hybrid strategies. The idea is to combine the best of both worlds. Use CSP, usually LVBAP, to get rapid physiological activation of the septum, but also place a traditional LV lead via the coronary sinus, LVCs, to help activate the lateral wall of the LV more quickly. This combined approach is sometimes called LOT-CRT, LBB optimized CRT, or HOT-T-CRT, his optimized CRT. The goal is to achieve better resynchronization by fusing the activation from the conduction system and the myocardial lead, potentially overcoming the limitations of either approach alone in these difficult patients with distal or mixed disease.
Yeah.
Early observational data looks quite promising.
And just to tie it back, we mentioned BBP might prevent AF. Does CSP in general have any impact on AF burden compared to older pacing methods?
There's definitely a suggestion in the data. Several studies comparing CSP, both HBP and LBBAP, to traditional BBP-CRT have reported a lower incidence of new onset atrial fibrillation in the CSP groups. It hints that perhaps maintaining more physiological ventricular activation helps protect against developing AF down the road. Now, for patients who already have persistent AF and also need pacing for rate control, often after AV node ablation, the pace and ablate strategy, CSP offers a way to provide that rate support with physiological ventricular activation. However, pace and ablate inherently sacrifices AV synchrony because you've electrically disconnected the atrium ventricles. So while CSP makes the ventricular pacing part better, if the goal is actually restoring sinus rhythm, you'd still need to consider pulmonary vein isolation, PVI ablation, as a separate crucial step to treat the AF itself. Hashtag tag tag outro.
Wow, this has really been a journey through the evolution of cardiac pacing. I think the absolute core theme that comes through is this realization, maybe a delayed realization, that standard right ventricular pacing wasn't benign. It was, as you said, iatrogenic disease. And acknowledging that harm was the catalyst for this whole shift towards physiological timing.
Absolutely. It forced a complete rethinking. So where we stand now, broadly speaking, for straightforward bradycardia patients, especially those with good heart function, BVP didn't really prove itself better than RVP, which is why these big CSP trials comparing directly against RVP are so critical. They'll likely define the future standard. For the more complex patients, those with heart failure and LBBB needing CRT, CSP definitely offers a potentially more physiological way to resynchronize the heart compared to BVP CRT. But we still need that high-level randomized trial data, like from the big NCT trial, to confirm if this translates into definitively superior clinical outcomes, less death, less heart failure.
And even within CSP, the research is still ongoing to refine the techniques, isn't it?
Yeah.
There are still key questions about the nuances.
That's right. The big uncertainty the field is still actively working to nail down is whether the specific site of CSP matters long-term. Is his pacing truly different in outcome from LVBAP? And within LBAP, do those subtle differences in capture selective versus non-selective capture, or maybe just LV septal pacing actually lead to meaningfully different results for patients years down the line? Right now, both HBP and LBP seem effective, but figuring out the optimal site and the ideal capture pattern for each individual patient, that's really the next frontier to maximize the benefits. The ongoing trials will hopefully shed more light on this too.
Okay, which brings us perfectly to our final provocative thought for you, our listener, to ponder. We talked about that fascinating MyPace trial in HFpEF, where accelerated pacing actually improved quality of life and activity, challenging the old slower is better mantra derived from HFrEF. Given that HFpEF often involves a stiff, volume-constrained ventricle, does this finding hint at something deeper? Could it be that for certain types of structural heart disease, precisely controlling the rate and especially the timing of cardiac events is actually a more powerful therapeutic lever than simply trying to reduce the heart's overall workload with drugs like beta blockers? It really makes you wonder if we're just scratching the surface of understanding the unique electrical needs of different diseased hearts.
A really interesting question to keep in mind as you watch this field rapidly evolve. It flips some traditional priorities.
Thank you for watching The Funnel Effect.